HD3, Miami, Fort Lauderdale.
Here's the latest from ABC News. I'm Joan Bennett. A warning from the State Department for Americans traveling overseas. Don't take chances amid concerns of a possible terrorist threat by al-Qaeda. These travelers at Atlanta's Hartsfield-Jackson Airport.
It just concerns me because I always feel like they're not telling us the complete truth.
Honestly, I'm not too savvy on what's going on.
You can't live in fear.
Previous attacks have centered on transportation hubs, subway and rail networks, as well as planes and boats. The warning extends through the end of the month. The State Department also closing down 21 embassies and consulates across the Muslim world for the weekend. ABC's chief global affairs correspondent Martha Raddatz.
A senior U.S. official telling ABC News that this is an active plot coming from Yemen, where the so-called underwear bomber got his training and where radical American cleric Anwar al-Awlaki directed terrorist attacks until he was killed in a drone strike 2 years ago.
A stomach bug traced to a Mexican salad mix that was sold at Olive Garden and Red Lobster restaurants in Nebraska and Iowa. But the FDA hasn't linked the salads sold by Taylor Farms of California to illnesses in 14 other states. ABC's chief health and medical editor, Dr. Richard Besser.
The good news is that all of the product that was implicated in this outbreak is no longer on shelves in the U.S., and that's one of the reasons why Iowa and Nebraska were unable to release that information. The state laws in those states protect the distributors and manufacturers of food products unless there's an ongoing public health risk.
The Federal Railroad Administration has ordered U.S. railroads to adopt a series of safety measures in response to last month's deadly derailment in Quebec, Canada. The measures intended to prevent trains from moving unintentionally. Thousands filling Chicago's Grant Park for this weekend's Lollapalooza Music Festival. This fan's plan.
See as many bands as we possibly can.
Nine Inch Nails and The Killers played last night. This is ABC News.
Hi, I'm Diane Caradu. I'm a senior Medicare Patrol volunteer. Our program, sponsored by Medicare and the U.S. Department of Health and Human Services, helps seniors learn to protect themselves from Medicare frauds and scams. For instance, if you're a Medicare beneficiary and you're approached with an offer of free medical equipment or services, watch out. If it sounds too good to be true, it probably is. Call 1-800-MEDICARE to report it. And go to stopmedicarefraud.gov to find lots of useful tips and important information about new fraud-fighting tools that Medicare now has thanks to the healthcare law. New resources to help law enforcement crack down on criminals and return taxpayer dollars to the Medicare trust funds. And how you can get involved in the fight against fraud. Go to stopmedicarefraud.gov and help make Medicare stronger for all of us. A message from Medicare and the U.S. Department of Health and Human Services.
What's really happening behind the scenes on cruise ships? We're getting a better idea, says ABC's Alex Stone.
Everyone deserves a little more fun time.
Behind the glitz and glamour of cruising. Like any mass of people in one spot, crime happens. Carnival Cruise Lines has released data on 4 of its brands, Carnival, Holland America, Princess, and Seabourn, showing in the past 3 years among the 77 million people the company has carried, there have been 38 reports of rape on board its ships, 20 thefts over $10,000, and 5 people have died suspiciously. Alex Stone, ABC News.
No one can predict what's going to happen with the economy, but you can still protect your financial future. Call now to arrange a complimentary financial consultation with Andy Costa. Call 800-275-6703. That's 800-275-6703. Or go online to CostaFinancial.com. Andy Costa has been in the insurance and financial industry for more than 25 years, and he'll help you to develop sound strategies for growth, income, safety, and protecting your legacy. Call now to arrange your complimentary financial consultation with Andy Costa. 800-275-6703. That's 800-275-6703. His offices are conveniently located at 2740 East Oakland Park Boulevard in Fort Lauderdale. Call right now, 800-275-6703, or go online to CostaFinancial.com. That's 800-275-6703.
The opinions expressed on the following sponsored program are strictly those of the host, guests, and callers, and not necessarily those of this station, its staff, management, or sponsors.
Welcome to the wonderful world of wellness with Dr. Andy Mencia. This medical program, heard from 7 to 7:30 each Saturday, right here on WSBR 740 AM, is brought to you by the Adult and Geriatric Center under the medical direction of geriatrician Dr. Andy Mencia. Good morning, Dr. Mencia.
Good morning.
You always bring such special prizes
Thank
to
you for
the...
all the publicity on
Oh,
the...
yeah. Oh, yeah. We've had a lot of publicity for you. And, of course, you heard at the Boomer Expo that Mike in your dental department, he did
was
so well.
Excited. Oh, my God.
Yeah, it was great to have you there in some form.
Ex-veteran, so...
Oh, I know. It was perfect for him. Oh, yeah, this was great. But anyway, we of course, always deal in a lot of issues. And this particular... In fact... The one coming up, as you know, the Boomer Times, we did Happy Feet because we talked about podiatry. And, a lot of people don't go to a podiatrist. They think having a pedicure is the right thing. Well, it's not.
They rather go to the back surgeon and have surgery in their back than fix their feet.
Well, so that made a big impression, right? And so we did that. But now you brought an excellent guest with you. Why don't you talk about him?
Dr. Keith Robinson. He's an excellent pulmonary specialist and critical care specialist. So we are so honored that God has basically just put us together. I always judge my consultant by the patient. The patient tells you bedside manner, does the person care, does the person understand my belief, and it has been 100% positive feedback from the patient. Good morning, Dr. Robinson.
Oh, thank you for having me. I'm appreciative of being here.
We don't often think in terms of a pulmonary care physician. We always think, well, I'm in the hospital. That's usually when you need someone and they give you oxygen and then that's over. But apparently there's more to that.
Yeah, what I tell my patient, that is the worst time to meet a pulmonologist. The worst time.
When you're in a hospital?
Yeah, because now you are sick. Now you have, a catastrophe going on. So if you get a cardiologist at that point, a pulmonologist at that point, you don't want that. You want to prevent. And that's what, Dr. Robinson and I is working toward prevention. If you have emphysema, if you have asthma, what that means to the layperson is that the lung capacity, that reservoir that you have in your lung, like when you read my book on the kidney, we talk about the reservoir of the kidney. If the reservoir is ready to take more, you can do whatever you want to that kidney, and those kidney, and they will tolerate. Your lung, when you are 15-year-old and you are in sport and you can do whatever you want to, you can smoke a whole pack of cigarettes, the next day you can run again. But as you age and as you keep damaging your lungs, you start losing that reservoir. And that's why you see young people can have a mini stroke on the brain. They have a full reservoir on the brain. But as you keep having more and more mini stroke, that reservoir is coming down. So why don't we have Dr. Robinson explain what do we do when we send a patient, just like we send the patient for physical rehab. Can we compare physical rehab to pulmonary rehab, and how does that work?
Well, and again, thanks for letting me come on this morning to
speak. It's our pleasure.
You've done a really good job of explaining exactly what it is we try and counteract in pulmonary medicine. We know that smoking becomes the primary reason for many folks to lose their lung function. And so that would be the first level of prevention that we try and involve our patients in, is smoking cessation and is stopping the injury to the lung. When folks get to the point of having disorders that lead them to be short of breath, what we do in pulmonary rehabilitation is help them to learn to rebreathe. I think the idea is that for many folks, when they become short of breath, stop doing their activities. When they stop doing their activities, they become more inefficient in the level of activities that they need to do. Comb their hair, brush their hair, bathe. Making breakfast in the morning becomes the most difficult task for many folks.
Carry a conversation on the phone.
Absolutely. And so the idea is that once you start to perceive and have the recognition that you're having difficulty with your breathing, it leads you to be fearful and to not want to do other things because of the fear that you're not going to be able to catch your breath. Throw on top of that an infection, upper respiratory infection or a new cold, which again robs you of your reserve, then that's what typically puts our folks in the hospital. And so what we try and do in pulmonary rehabilitation is to not only the smoking cessation, but we try and make sure that we've taken those folks giving them the right level of education about their disease state, how significant their disease is, and we try and find their level of medications that, either by inhaler or other, can keep those symptoms low so that they're able to continue their activities of daily living.
So basically it's like when a patient, let's say, had a stroke and they have problems swallowing, they had to retrain themselves so they can relearn how to swallow and carry on a normal life.
Absolutely. And I think when we do our breathing retraining during pulmonary rehabilitation, we try and make sure that folks go back to the basics of how, and I believe in God, so how God taught us how to breathe, which was belly breathing. Because it helps you to use the lung as a bellows. It helps you to use the abdomen to assist with the level of breathing that you can do. And then we do other mechanisms, pursed lip breathing, which is essentially like breathing through a straw. But it creates a little back pressure in the lung so that you're able to exhale that stale air that's trapped within the lung, so that you're able to deflate the lung to a level where that's comfortable for you to take the next qualified breath in.
I have to just, when you said the belly breathing, I have to ask you about that, because whenever I'm doing any meditation or I'm listening to tape, so it says, breathe, from your belly out. I mean, what does the belly have to do with your lungs? Sorry, that's a dumb question, but
not at all.
Perfect question.
I don't understand that.
It's a lot of anatomy there, so yeah.
So the diaphragm, the primary muscle that helps you to breathe, actually helps to draw air in by contracting and pulling the abdomen down. And so belly breathing is exactly that. It's your diaphragm pulling down, which allows you to expand your lung. So that's primarily, if you look at infants when they breathe primarily through their belly, because they're learning how to utilize their diaphragms to help them to breathe during the first few months of life. And so we try and get back to that. We started to breathe with our chest, with our muscles within the chest wall as we age, and I think a lot of that is stress-related, and the fact that we all like to walk with an upright posture. And so over a period of time, we stopped learning and we stopped utilizing our diaphragm the way that it was designed, which is to draw air into the lung by pulling down.
So it's like an accordion.
Absolutely.
You have to expand the accordion in order to play the music.
So,
he always does that. He takes these wonderful analogies and he makes it so clear.
And I'm going to take that, by the way.
Yeah, that's right. It's an accordion. Use your accordion in and out, right? And so the nice thing, and I have to share this with everybody, that Dr. Mencia, of course, is located on Commercial Boulevard, just a couple of blocks or a couple of miles a little bit west of Holy Cross Hospital. And he owned the building next door, and he didn't know what to do with it. And lo and behold, it was the angels
I knew
brought
what to
it.
Do with it.
Yeah, you just didn't know.
Forgot to
that's
make
right.
Decision.
That's what happened. The angels came, and that's now where. And what is the actual name of your company?
It's Fusion Health.
Fusion,
lung, heart, and wellness.
Fusion Health, lung,
heart, and wellness.
Heart and wellness. Oh, that's just fabulous. And what is the number if someone wants to call you?
Our number is 954-900-5635.
Good. Okay. And this is Dr. Keith Robinson.
If they have a problem getting a hold of anybody,
we'll go
they
to
can
you.
always call
yes.
Patricia at the office, and she'll take a message and make sure that the staff will get it because we work together.
Well, I was just going to say that probably the best way to do this is to call Dr. Mencia, make an appointment. They're open on Saturdays. Are you open on Saturdays?
We're not open Saturdays.
Not yet. Oh, listen.
Not yet.
Soon. We have this whole thing open on Saturdays. So to go to talk to Dr. Mencia, and now he will, of course, if he believes this is the right thing for you, will refer you over to Dr. Robinson's organization, which is Fusion.
And we're right next to each other.
Yes, so right next door to each other in a beautiful building, and I'm really happy to have had this happen. Can you tell me, Dr. Mencia, we hear so much about the COPD. Tell me about that.
Well, COPD is when the patient develops what normally people say as emphysema of the lung. And what happens, you start losing the area of the lung that is supposed to be responsible for the exchange of oxygen and waste material out of the lung. So as you lose more and more area of that, so imagine if you have a whole football field dedicated to the exchange of oxygen, and as years go by, you have less than a football field left. So you have to do all the exchange of waste material out of the lung, as well as bring oxygen into the lung. The retention of that waste material within the lung and the lack of oxygen by the lungs will affect each and every organ of your body, including the largest organ of your body, which is your skin. So everything get affected when you affect your lung with emphysema.
So, and Dr. Robinson, you must see a lot of people with emphysema, and once someone has emphysema, they can't get rid of it, can they?
No, and that's the sad part about lung disease that I have to treat on a daily basis is that I have to work with folks who don't have the reserve that Dr. Mencia was referring to. They're working with a third of their lung capacity left, and so there's not a whole lot of wiggle room to work with, unfortunately. But that's where rehabilitation comes in. Because the idea is that with those folks, even at the lowest level of lung function, we can still work with them. We can still help them to improve their exercise capacity, their efficiency, by doing mechanisms that show them that slowing down. For some reason, folks always want to continue to work and move as fast as they can, but
and we don't discriminate.
And we don't.
And we don't discriminate. So if you smoke, because this is where people go. A lot of people are so afraid to go to a lung specialist or to talk to the doctor because they say, I am smoking. It's like I am not going to the synagogue. I'm not going to church because I'm a sinner. Of course, you are still welcome to come to the prayer place.
Good point.
Okay, so we take the same attitude at the prayer place. You can come in. I don't care if you smoke. When my patient come to me, if they smoke, they are okay. They are still welcome. And I work with them. And I tell them, I will wait until you decide that you want to quit. And hopefully you want to quit before you lose your lung, before you develop an embolism in your lung, before you develop cancer. Hopefully you want to do that, and then we're going to work together. I'm going to be here for you always. And Dr. Robinson had that same attitude. He see the patient, we know they smoke, they talk to us about their smoking problem. And why don't we talk about the smoke cessation program within the pulmonary rehab?
Oh, really? Oh, how fantastic.
It's a key component. I think the idea is when we still have folks who are working, and we know that a large majority of folks with COPD are actually under the age of 65. So they're still out in the workforce. And so they have many years and decades of life left if we can get them away from their cigarettes. And so that's a huge component of smoking cessation and pulmonary rehabilitation is to remind them that they still have a number of years left in life, and that the sooner they stop, the better we can preserve what lung function they have left. And so, I think everybody tries to do nicotine replacement. It's kind of the foundation of how we get folks off of the smoking habit. But there are auricular therapies. We have Dr. Lara in our office who does auricular therapy. But there's
what kind of therapy?
Auricular therapy. It's a little like acupuncture that we can utilize. 10 unit across the ear. The idea is that there are things to modify the craving that we can provide for folks. And the idea is that we have to view the addiction as for what it is, as an addiction, and treat it as such. And so behavior modification, counseling goes along with that. So you have to sit and talk about the usage and the need for a cigarette. And once people have an opportunity to talk about why they're smoking, many times they find that it's not because of any physical need. There are more psychosocial issues that come up that require them to want to light a cigarette.
So, Dr. Robinson, why did you become a pulmonary specialist when you probably could have become any kind of a specialist?
I got a master's degree in exercise physiology, and when I decided, and maybe it was a little bit of arrogance, I decided I wanted to become a physician. During my internal medicine rotations, I found pulmonary medicine. It was something that matched a lot of what I'd learned in exercise physiology, and certainly with the critical care side, gave me a little bit more intervention with folks who really needed a physician who was willing to be at the bedside for them. And so it was a subspecialty for me that matched everything that I wanted out of life.
So Dr. Mencia, asking about, there are people who have a lung removed, and they then have one lung. Now, how do they do with one lung?
Just like when you lose one kidney, you just function. You just function with one lung. Same thing, The thing is, a lot of time we tell the patient if they lose a kidney, you have to let each and every person that you go to, every provider that touches you, you have to let them know I only have one kidney left. Same thing if you only have one lung left. If you have one lung left and somebody is smoking even close to you, secondhand smoking, you better move away from there. You don't have that much room to play with.
And so the decision to have a lung removed, is that something then they would deal with you as well? I mean, Dr. Mencia, with you do a consultation, decide about this?
Yeah, the idea of removing a portion or part of the lung is not a small one, because the lung doesn't regenerate once it's damaged, and certainly when it's removed. So the idea is that there's a large amount of workup and a large amount of exercise that needs to be done prior to that event, meaning that the time that the physician decides it's time to take the lung. So for many folks, we do a large amount of review of how much blood flow is going through the lung, how much oxygen is required to keep the patient safe. Some folks actually oxygenate out of a different lung that needs to be removed, which is good. But if their primary lung that needs to be removed is the one that they're oxygenating out of primarily, then in that setting we may run the risk of causing a situation that we call pulmonary crippling. And the idea is that if somebody wasn't short of breath prior to the surgery, am I going to make them more profoundly short of breath with the surgery? And so when we determine that up front, we can give a better assessment to the patient and help them with the risk-benefit analysis that's necessary before doing something so dramatic.
Complicated.
It is. And I think the idea is that if we're going to get to the point of removing a part of the lung, we want our folks to be as well informed as they possibly can prior to the surgery so that they're able to be safe.
Well, that's wonderful. You know, Dr. Mencia, you always do this to me. You never tell me who you're bringing. You always surprise me with these brilliant people, and I'm just always learn. I'm like a sponge learning all this. So Dr. Keith Robinson has the organization called Fusion, and it's called Fusion Health. Let's see, Fusion. You do it again for me.
Fusion Health, lung, heart, and wellness.
Fusion Health, lung, heart and wellness. My goodness, that's a great name. And so you'll want to call Dr. Mencia, of course, and I'm going to give Dr. Mencia's number. That's 954-489-1345, 954-489-1345. And you're going to want to find out, make an appointment. You can see him. His website is adultgeriatrics.com. Now, if you are interested in the smoke cessation program, you can call the Fusion Health, and that number is 954-900-5635. I'll repeat that again, 954-900-5635. And I've always told people, sometimes people just don't get their pencils fast enough. I can't talk slower than I do. I try. Call our office at 736-8000, and that's 561, and we'll always give you people's names and help you. So, Dr. Mencia, how many people that you see really do need to have this kind of help with pulmonary help? Is it a common thing?
It's very common, and the way I see it, when we apply the holistic approach to medicine versus just the traditional, but fusing the holistic and traditional medicine, you get so many patients. The other day we saw one patient that the patient had a cough, a persistent cough. And I said, well, I want you to see Dr. Robinson, the pulmonologist, and see how we can work together. I said, but I don't smoke, I don't have any problems. It's okay. Let's say you have a cough. It's come from the lungs, so it could be, a ear, nose, and throat, or it could be a lung specialist. But your lung is so close to your heart, so let's go to the most critical organ first and go there. So Dr. Robinson saw the patient, and one of the blood pressure medication the patient was taking from the cardiologist was producing the cough. So the suggestion was, let's discontinue this medication, replace it with another medication, and the cough went away. So you have this patient that walk around their life and say, well, I have a cough and nobody can do anything about it. What we do at the center, we integrate the care. So it's an open system where Dr. Robinson and I can talk to each other while the patient is there. The cardiologist, Dr. Robinson and myself, we all can sit down and we can come up with a strategy, put our head together with a simple problem and try to solve that problem so that the end result is that the patient has a better quality of life.
And, Dr. Robinson, I have to tell you that before you met Dr. Mencia, you probably didn't know he even existed. And did you?
To be honest, I'm embarrassed to say that out loud.
No, but it's true. Listen, until I met him, which is probably about 3 years ago, I didn't know either. But you will find, and I just have to say this, and I try not to be prejudiced about this, but although I am very much prejudiced for him, but he is unique. It's rare to find a physician who says, okay, just sit down. We're going to really look at everything in your life, not just shoot pills at you. But he really is a diagnostician, I always say. That's really what he's a geriatric physician, but he is a diagnostician, and you don't find many of them. He takes the time. His staff takes the time. He finds people like you. I mean, I've had people on the show that he brings in, and I just sit there in amazement. Where did he find this person? But you really have this. I think, has anybody ever said that to you, that you really are a diagnostician?
Yes.
You should really. You know what I don't think we do? I think we have to do this. I mean this. I think we have to have something about a diagnostician, because there are a lot of people with illnesses, and they're looking for someone to diagnose that, and they don't just want to go to a regular doctor.
I had a patient that came to me. She has abdominal cramps. And they even sent her, she went to the Cleveland Clinic, one of the major institutions here in Florida. Went to Jackson Memorial, went to different organizations trying to see who can help her. And, her husband is a well-known lawyer in the community. So the husband said, let's go and see Dr. Mencia. So they came over to see me. And the lady is from Greece. And they wanted to do surgery on her. She was refusing. Like, why are you going to do surgery?
Surgery, right? Why this is happening?
They say, why? Why are you doing this to me? You mean you did a CAT scan, you did an MRI, you didn't find anything. Why are you doing surgery? We don't know. We just want to look in. No, you're not opening my belly. So the husband brought her by. And what she had is Mediterranean fever. Well, a condition called Mediterranean fever that is very common in people from the area of the Greece, and we solved the problem with a very cheap medication called colchicine. One a day, and problem solved. So I love that. I love the challenge. I love people to bring me a problem that they have. And, two things I want to do. I want to get to the bottom of the problem. I want to know what's the root of the problem. But the major thing that I love to do is to prevent. I'd rather have a person see Dr. Robinson because they have a simple cough, and I don't want any of my patients to be diagnosed with cancer. I don't want any of my patients to end up with oxygen for the rest of their life if we can prevent that. So that's why I think, the marriage between me and him had been absolutely fantastic. I'm so pleased. I'm so excited. I can see the future for both of us just moving forward, and our patient coming right along, and I'm feeling better and doing better.
So, are you also, when someone comes in, as Dr. Mencia was saying before, and they've had maybe a stroke, I would think it does affect, and usually a stroke is half. Is it affecting half of their body, and the breathing is just coming from one side, or does it not affect the lungs?
No, a stroke certainly would affect the lung, and I think the idea, not just does it affect the ability to breathe efficiently, but it also increases the risk of infection. So the ability to cough and clear, it becomes a primary concern when folks have a neurologic injury like a stroke.
Wow. See, so
they become more prone. So that's what we do. We take the holistic approach. We look at the entire person. So having Dr. Robinson there with his specialty in the lung, but he's looking at the whole body. He's not looking at two lungs walking by themselves there. It's the whole body. And, a lot of people don't think of a stroke affecting lungs. Say, well, if I never smoke. But the thing is, if you had a stroke and you lost capacity of one side of your lung, then you say, well, I'm so tired. I'm always so tired. I have no energy because you don't have enough oxygen. If you don't have enough oxygen and you are tired, you're going to gain weight. And these are the things that will make you prone to that next stroke. And the next stroke usually is going to be worse than the first one. So at the center, we try to integrate to see, let's put everything we can on this individual to prevent the next stroke. Let's be proactive.
So there are people out there, and this will be the final question because we probably run out of time, and if we get through this. There are people that I've heard recently, I just heard yesterday, as a matter of fact, 4th stage lung cancer. Does that person come to you and you help them because now they can hardly breathe? And is it, I'm not going to use the word, is it worth doing? I would think to ease their pain, even though they're on chemo, they're on radiation. Is that a good thing for them to come to you?
Absolutely. I think the idea of palliation isn't to watch folks wither away in front of you. It's to remind them that they're still alive and that they still have life left in them. And so even with the most significant level of lung cancer or lung disease of either kind, it's that palliation of the wellness that they should still continue to try and strive for. And we understand that they're going to have hiccups and things that cause them to be symptomatic during the day. But the idea is that if we watch them carefully and give them the things that are required to make sure that they remain safe, I think they would say that each day is a qualified day, a better day than the day before. And that's the whole idea, is to make sure that we're always giving our patients some hope.
Well, you really you found a star.
Yes, and for the audience, just to remind them that
you open on Saturday. No, I'm sorry.
We'll open on Saturday. We do home visit.
We do home visit.